Good evening, everyone, and thank you for joining us for tonight's event. We have Dr. Kriti Bhagat here with us, and she is going to be speaking on Beyond Correction, integrating mental health and functional outcomes in the management of keratoconus. My name is Dr. Ariel Sorenzi, and I will be your host for tonight. And a big thank you to Glaukos for providing an educational grant for this event. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, please fill out the survey that's in the chat, and it'll also be there when the webinar ends. CE certificates will be delivered via email and sent to ARBO with your OE tracker numbers, and we will also have a QR code at the end of the event. So if you can just get your OE tracker app out and scan it with your phone, you'll have that credit instantly. Otherwise, those CE certificates will be emailed to you within about 4 weeks. If you would like to ask any questions to our expert here, you can ask it in the chat or the Q&A at the bottom. And you can also find that if you are on your phone at either the top there for the Q&A, and then the chat is under the three dots under more. So I am so excited to introduce our speaker tonight. Dr. Kriti Bhagat is a graduate of the Pennsylvania College of Optometry at Salus University and completed her cornea and contact lens residency at Salus. She is the owner and founder of Ideology Vision, a cold start private practice concentrating on cornea and specialty contact lenses. She is an adjunct professor at Salus University, a continuing education speaker, and in her spare time, she is a book editor for publishing houses. And you also have a really cool Instagram, which I think you should tell people about because I love it. And we're so excited to hear from you tonight.
Well, thank you. Thank you so much for having me.
And here are our financial disclosures, all of which have been mitigated.
Perfect. Thank you so much for introducing me. And yes, you can definitely tell I have a reading problem based off of the background. Um, Thank you everyone for being here. And again, thank you for having me back. I am honored, especially because I'm talking about something that is so dear to my heart and something that I get to do every single day, which is managing patients with keratoconus. So today it is a little bit of a continuation of a previous presentation I've done, but trust me, there will be enough of a review. I will throw a lot of the pearls in that I talked about earlier and kind of talk through some new things. So again, today's title is Beyond Correction, how we try to take a look and how we get to integrate mental health and functional outcomes in the management of keratoconus. So again, we'll have a little review on keratoconus, review of mental health effects, quality of life effects, goals and treatments that we talk to our patients about. And then I really want to focus on how we can help our patients beyond just our exam room, right? So we want to talk a little bit about the roadmap for comprehensive care and then how we can make small in-office changes, whether it's with our staff or how we present a diagnosis, and how those changes can go a long way with each one of our patients. And I hope that every one of you gets to walk away with a little pearl on how you want to take back and make a change when you're seeing your keratoconus patients. So we know this. I'm sure everyone here tonight knows the definition of keratoconus, right? So what I want to do is take this definition and maybe look at it from a different perspective. Keratoconus is a chronic progressive corneal ectatic disorder. It's characterized by a conical protrusion of the cornea, thinning of the stroma, and irregular stigmatism. But it is so much more than that. And so when we think of our keratoconus patients, you know, with each one of your experience of how keratoconus is not just this disorder that's defined by this definition. And you'll see that by the end of this presentation. And that's my hope. One of the biggest difference with keratoconus compared to some of the other disorders is that it starts at a young age. That is not something that these young patients are prepared for. And that goes a long way when and how it affects their mental health. It's a threat to possibly having vision loss or blindness, and now you're combining that at a young age. And also, these patients are getting a disorder that is going to be a lifelong management. It is not something that they go in, they fix, and they're done with. This is something that they'll have to think of for the rest of their life as we are managing it in different ways. And so These three things I think are the biggest difference when we're talking to our patients about keratoconus versus maybe something like macular degeneration, something like diabetic retinopathy, right? Not to say that those things are any less than keratoconus, it's just how this is different for our patients. Right now, when you take a look at the testing, right? When a patient comes in and whether they're a referral to your office or you're just seeing a keratoconus patient, our testing usually is symptoms, taking a history, right? Family history, autorefraction, keratometry, some of our basic tests, visual acuity, look at signs, slit lamp examination, refraction, and then we have our additional testing that we may focus on for the cornea, like a tomography scan, or even anterior segment OCT. When we diagnose a patient, so I will tell you, just a few years ago, for me, when I diagnose a patient, I would review the findings with the patient, present the diagnosis, give them a little bit of educational information, and then from there, make a follow-up appointment. I'll see you back in a few months. We'll talk about this. We'll do the scans again, right? Fast track to now, think I've changed a few things, but what else can we do, right? When you present this diagnosis to someone, especially the first time they're hearing the full diagnosis, they're looking at all the scans that we have for them and listening to why we think they have keratoconus. What other data points should we be looking at, right? What other things are we going to evaluate when we're making that diagnosis? And what other considerations are we putting into this diagnosis? That also goes to treatment options. So let's say you make this diagnosis. Now, the next thing you're going to do naturally is talk about treatment options. And that's exactly what I do, right? I'm going to talk about, all right, let's go ahead and come up with the glasses prescription for you. All right, next thing, contact lenses, whether they're soft or specialty lenses. Next, I'm going to talk about cross-linking, whether that's an option or something that we'll look into in the future, and then making a follow-up appointment or having a referral appointment. What more can we do for these patients, though? These are simple things that we're doing from an eye care perspective. But what other things are we looking at? And I hope that as we go through this presentation, we look at what other data points we can evaluate and other things that we can consider so that maybe we can talk about other treatment options or even how we present our treatment options. It's a lot. It's a lot for our patient. You're sitting there, you're giving them the diagnosis of keratoconus. You're telling them, look at these scans. This is what all these scary scans say. We're going to need some glasses. Maybe glasses won't work for you. Contact lenses. I need to do a few more scans to really diagnose this. Then you get to the point where you're thinking about cross-linking. You're going to talk about surgery. In the patient's mind, they're thinking, surgery? Wait, will my insurance cover this? How much are these contacts going to cost? Ooh, what other doctor do I have to see? More appointments, progression? It's a lot of things that they have to take into their mind, right? This is where I say stop. This is where I think we stop and we reevaluate how we're presenting this. Because to us, it's something that we do. All right, we see the patient, we make a diagnosis, we present the diagnosis, educate our patients, and give them treatments. And I'll be honest with you, for me, that's a win. I'm excited. I'm excited to be able to help this patient. I want to get this information out. I'll be selfish and I'll tell you that I feel really proud. Hey, I had a win today. I took a patient that was 2100 and I fit them with specialty lenses. They're going to be 20/20. It's not really about me anymore. It shouldn't be about us, even though it's really hard to say that. This is where we stop and think, what is going through that patient's mind? What is this patient? How are we preparing our patient to handle this? And this is where I say we stop and we reevaluate how we're doing something that we've been doing for a long time. Before we get into some tips of how we can change that, let's talk and create a basis here. Mental health, right? Mental health is a state of mental well-being that enables someone to cope with the stresses of life, realize their abilities, learn well, work well, and contribute to their community. Now, the mental stress of becoming blind is really there. It has been studied in many different studies and articles and journals that's out there. When patients receive a grim diagnosis or poor prognosis, Our patients tend to experience worries, anxiety, fear, depression, and an interesting one is social isolation. 1/3 of people with visual impairments experience subthreshold depression and or anxiety. And then when it comes to our interventions, and when we're going through these with our patients, our interventions are less effective on increasing psychological well-being, especially in the elderly. So as they get older, these interventions that we have are becoming less and less effective on them. Depression. It is a medical illness that negatively affects how you feel, the way you think, how you act. Depression causes feelings of sadness and or loss of interest in activities that you once enjoyed. Think we've all seen those commercials out there, right? And when you're listening to that, you get that feeling. So take that feeling and engulf that into you of when you're talking to your patients with a diagnosis. This can also lead to a variety of emotional and physical problems. It can decrease your ability to function at work and at home. Depression and visual impairment have a direct correlation. So as patients have vision impairment, there's a disability that occurs. This can lead to depression, and it also leads to decreased motivation and determination. Vision loss is associated with mental fatigue, less social contact, and can induce feelings of loneliness and social isolation. Again, that loneliness, the social isolation part, that's a pretty big one that as you start talking to your patients, you'll realize you hear it more and more, no matter whether it's keratoconus or other vision impairments. Trials have shown that problem-solving interventions can improve vision-related functioning and emotional distress, but not depressive symptoms. So this is where we start thinking of, all right, problem solving. What are interventions that we can make to help our patients? Some different examples of psychosocial interventions are group therapy, art therapy, animal therapy, counseling, and vision therapy. There are definitely more, but these are some of the ones that are out there. So I'll tell you an interesting story. I saw a patient a couple of years ago, and I have a little bit more about her a little later on, but she's actually an artist. She's young, she's an artist, and she teaches, she's a TA in some classrooms. And when she was diagnosed with keratoconus, one of the ways that she kind of coped with that diagnosis was by doing art therapy. And it's interesting because as soon as she was going through this, she had her cross-linking. I asked her if she would host a paint night in our office. And it was one of those things where we hosted a paint night for our keratoconus patients. I let her lead it. After the paint night was done, she was the first one to come up to me and say, thank you. Thank you for letting me host this. Thank you for having other people that are here that I could talk to. And so this goes a long way for our patients that we don't think of, but in a way that not only did it empower her and give her a purpose with her diagnosis, but also gave her the opportunity to meet other people. Anxiety. Anxiety is something that I can say many of us know this feeling, right? It's an emotion that's characterized by feelings of tension, worried thoughts, and physical changes like increased blood pressure being one, right? Anxiety is not the same thing as fear. It's often used interchangeably. Anxiety is considered a future-oriented, long-lasting response that's broadly focused on a diffuse threat, versus fear is a little bit more about present-oriented and short-lived response to a clearly identifiable and specific threat. Again, anxiety and vision are correlated. When we look at our patients, patients with vision impairments are about 7.5% more likely to have anxiety disorders, especially feelings like agoraphobia and social phobia, than peers that are normally cited. Fear. So fear, on the other side, is more of a basic, intense emotion that's aroused by the detection of an imminent threat. It involves an immediate alarm reaction that really mobilizes the person or organism into triggering a set of physiological changes. This is something that has been studied also, and many times when you encounter a patient, it's more so from my experience, I'll tell you, that I've picked up as I've read a little bit more about fear and vision impairment. What I usually see is that when you initially diagnose a patient with keratoconus, I see these signs of fear, right? So I have seen patients go through these 7 stages of grief. There's shock and denial at first, there's pain, and I've had patients ask, well, did I do something? Was it something I did, right? Then there's anger and bargaining that goes through. There's a little bit of that depression factor. There's a little upward trend turn that I see when we start correcting their vision. And then there's that reconstruction working through, leading to acceptance and hope. Does it always happen this way? No, it doesn't. And does it always happen in all the stages? I don't think so. But I do think that after understanding these 7 stages of grief, I can tell you in the past, when I diagnosed a keratoconus patient, I would say I was excited. You could see the little excitement on my face, again, for a selfish reason, because I get to fit the patient with maybe a specialty lens and change their life. But what I see on the other side is instead of seeing the patient being excited about this and that there's hope, there's usually a quietness in the room. They're analyzing it. And so, depending on where the patient is, there are these different stages of grief that they can go through. And it's our job to kind of take a step back and maybe take a look at what they may be experiencing. Loneliness. So loneliness can really affect self-regulation, sleep. There's psychological, physiological findings that can change. There's psychological findings, there are gene effects, immune functioning. Loneliness can affect a lot. So one of the things that I realized with loneliness is really kind of picking up and maybe asking patients who their support system is if they're here by them, if they're present by themselves, right? Sometimes they are here with someone else and kind of asking them what their home environment is. Loneliness can really lead to increased depressive symptoms. As you can see, there's increased perceived stress, there's fear of negative evaluation, anger, anxiety, diminishes the optimism and self-esteem. And so this all leads to increased morbidity and mortality. And that's all been studied. So when you think of that and you see someone that's showing up to your office and you're diagnosing them for the first time, I don't outright like asking someone if they're lonely, right? That's kind of awkward. That would probably be something I would do. But I've learned and I'm better now, right? But I like asking them a little, if maybe later on when you're having the conversation about, all right, the next steps, maybe the surgical steps, and asking if there's someone that can bring them, right? Who else do they talk to? What support system do they have at home? So that, I think that goes a long way in understanding your patients. As you can see, again, correlation between loneliness and vision. There's a significant prevalence of moderate to severe loneliness in those with vision impairment. Higher levels of loneliness can also lead to lower life satisfactory scores. I think these are things we know, but again, evidence-based medicine really tells us that these are things, and these are things that we should look out for, again, when talking to our patients and understanding our patient. So with all that information, right? Looking at these different emotions and different traits. You take a look at fear, you take a look at anxiety, depression, loneliness, knowing the correlations between that and vision impairment, and then knowing where keratoconus can be and how it can be at different stages for different patients, it makes me think of, all right, again, stop, reevaluate, right, of who's sitting in your chair and what they may be experiencing. Doesn't mean I talk to every patient and say, hey, are you depressed? Are you lonely? Are you experiencing fear? But those are things for me to understand because, again, I, in the past few years, understanding this part of things, that there's such a big mental health impact on keratoconus patients, I think I take a step back and I try to think of, all right, how can I better understand the patient? And that's really the big point of today and how we can understand them. So, understanding the patient. Back to that. So there was a literature review that was done. There were about 31 articles focusing on the negative effect on mental health or emotional well-being of a keratoconus patient. There were various questionnaires that were used and looked at in this literature review, and it was done from various different countries. It's interesting to see what was found. What was the results of this was worsening health scores with lower visual acuity in the better eye. They found that there's an increasing, especially an increasing ocular asymmetry, corneal curvature, and worsening disease severity. They found that Asian countries had little to no correlation, which I had to look up as to why. And it was interesting to read the discussion part of this because I can understand this. With having an Asian background, mental health perception in Asian countries is very different. It's a little bit of a taboo, and a lot of people don't like talking about it. So I wonder, and as they did with the authors in this literature review, that maybe it was that there was no correlation because many people don't either get the help or the care, or they don't realize that there are mental health concerns because of the perception that's there. When they compared keratoconus to macular degeneration, diabetic macular edema, and RVO patients, they found that keratoconus patients had the highest mean visual acuity. So, best basically visual acuity, but had the worst quality of life and emotional well being scores. The lower scores in patients was a little bit more so with progressive states versus stable states, and patients with keratoconus had more dysfunctional coping mechanisms. So, when we take a look at this, why is it? Why does a disease that does not always render a patient with severely reduced visual acuity can still have a marked impact on the quality of life and mental health? So, are patients seeing well compared to some of the other disease states, but then their quality of health and mental health scores are so low? Well, there's a few different factors, right? And we can talk about each one of these in depth, but when you take a look at it, there's different points that can be kind of looked at. There's changes in ocular surface and tear film. There could be contact lens intolerance. There's ocular pain that can go with this. There's a need for frequent visits for these patients. That can be a big impact on them. They know they're coming back again and again. They're going to sit through a doctor's office. How many times do you hear patients say that they've had to wait for an hour or more in a doctor's office? So think about that, just knowing that there'll be multiple visits, right? And then you have anxiety of progression and unknown visual changes. So you're not sure. You're not sure, is this going to progress? Is this not going to progress? Will it lead to blindness? I know it can. I don't know about you, but I know for me, for several different health concerns, I have Googled things. And when you Google things, oh boy, yeah, my headache could have led to something that could not be good, right? Versus just saying maybe I should drink more water. But think about that anxiety that you have when you Google something about yourself, especially when it's a health concern. And think about how these patients have this anxiety and they live with that because they don't know it's going to progress or not. So, understanding the mental health concerns with keratoconus patients really helps an eye care provider change their conversations, their treatment plans, even their treatment plans when taking care of these patients. So, when it comes to how we present, right? I want you to stop and take a moment to think about, how do you present the diagnosis? What do you normally do in your practice? Like I said, in the past few years, I've probably changed the way I've done things, and that's probably because I've really gone down a major rabbit hole looking into all this research, which has been great because I want to say it's better for my patient, right? But what do you do normally? And then when it comes to treatment options, how does this conversation change the way you present your treatment options? Now, before you completely think about changing your treatment options and how you present them, I want to talk a little bit about personality traits. So, personality traits. A personality trait is a relatively stable, consistent, and enduring internal characteristic. This is something that's a little bit more stable and it's not more your reaction or emotion that you're having. This is inferred from a pattern of behaviors, attitudes, feelings, and habits that that individual has. Now, if you look back, and I can go back probably to the 60s and 70s, looking at different journal articles, keratoconus patients have an interesting description. And I want to break that thought process. Even though some of these are negative traits, I want to really try to break that thought process because it shouldn't be from a negative perspective. Keratoconus patients in different journal articles have been described as odd mentality, having compulsive scratching, emotional crisis and upsets, unusual, paranoid, bizarre, and even untrusting. The CLEC study described that quality of life of keratoconus patients being similar to moderate to severe AMD patients. And then in other articles, it's also been described as patients having psychoanesthesia, and schizophrenia. So these are the descriptive words that have been used to describe our keratoconus patients. There's a study that was done. It was a case-controlled study with 60 subjects. These 30 with keratoconus and 30 healthy control patients. The quality of life was assessed. Psychiatric assessments were conducted. The temperament was evaluated, which refers to more of a genetically determined emotional reactivity to the environment. This leads to a development of personality traits for patients. And there was also a psych evaluation that was done. So it was a structured interview, and there were 3 self-assessments with that. And what they evaluated were factors like mood disorders, psychotic disorders, there were somatic disorders, and attention disorders, and a few others. The results of this was keratoconus patients are more prone to mood and anxiety disorders than non-keratoconus patients. About 88.9% of keratoconus patients qualified as presenting with obsessive compulsive personality disorder, and about 11% were with avoidant personality disorder. I want to just stop right there. That's a big number. This is one study with a small pool of candidates, right? So it was a pretty large number for that. And so that's one of the things that you have to take a step back and take a look at, that this does not prescribe all of our keratoconus patients. It's a study, and the number of subjects was pretty small. But with a number that high, think of it. If your patients if the keratoconus patients are presenting with this obsessive compulsive personality disorder, I can understand and see why some of these patients kind of jump right into kind of asking all these questions, jump to conclusion, right? And they're thinking about, okay, what are the next steps? And then I also see from personal experience, I've also seen that there are patients that kind of close up. They quiet down, they close up, and I can see that they think that maybe if they don't come back for their appointment, or, if they don't address this, maybe it will go away. And that can be the avoidant part of this. When this study took a look at the temperament of patients, they also took a look at keratoconus significantly scored higher on things like depressive, cyclothymic, and irritable temperament scales. Keratoconus patients scored significantly higher on the neuroticism scale. There were higher scores in subscale parameters such as somatization, obsessive compulsive, interpersonal sensitivity, hostility, and psychotism. Now, again, I want to take a moment and just say, yes, this is what was described in this study, but these are sometimes perceived as negative words. And that's not our job to take that and portray that and think that every single one of these patients is going to be a patient that is negative. I will say, after reading this study, I took a moment to think, wait, are my keratoconus patients going to be hostile? No, that's not what you're thinking. What I perceive from this is that we're supposed to take a moment to think that these are the feelings that they can experience, right? These are the things that they can. And now how do we guide them through coping and processing a diagnosis in a different manner? So back to the treatment options part. It's not a one-size-fit-all answer for these patients. There are multiple factors in play. There's age, there's time of life, finances, length of treatment, support system a patient may have. There's so many different factors that play into this. And so I want to take a look at quality of life and add that into that, because that can also change the way we talk about our patients' treatment options. So when it comes to quality of life, how does the diagnosis of keratoconus affect our patient? We want to come up with a personalized plan for each one of these patients, right? And then what we want to take a look at is their priorities. First, what are their visual goals? And then what are their non-visual goals? So in the last presentation I did, I really talked a lot about quality of life. So I tried to condense all of this into one slide instead of going into all the different factors. Quality of life plays a major role in keratoconus patients. Many studies have evaluated that. And what they found is there are different factors that can affect that quality of life part to a patient. Different keratoconus levels can affect that. Cross-linking versus non-cross-linked patients can have different quality of lives. Scleral lenses can impact the quality of life of a patient in a very positive way. And then also surgical interventions, knowing that there are surgical interventions, knowing that there are some surgical interventions, such as cross-linking being one of them, that can help slow or stop that progression, can make a big impact in the quality of life of the patient when it comes to worrying. So these are things that can impact that. So based off of many different studies that have looked at the quality of life, there are different questionnaires that you can add. For the past 2 years, what I have done is I have added a questionnaire into our office. I will tell you, I do not like doing this questionnaire for the first time when a patient comes in and is diagnosed. This is something that I like doing maybe after. It's a lot to throw a questionnaire at a patient. So as validating as it can be to go through this, I think it's a little better at a second appointment or a follow-up appointment where you do initiate this questionnaire versus the first one. What you're mostly doing is you're doing a lot of testing, a lot of educating on what keratoconus is, and then maybe talking about their goals. But this has been a game changer for our keratoconus patients and for me to understand them. So the first questionnaire has been the Keratoconus Outcomes Research Questionnaire. This questionnaire is based a little bit more so on keratoconus patients specifically. And you can see here that it's asking how much does your vision interfere? Maybe doing tasks like everyday tasks like driving during the day or computer screen. There is another questionnaire also, which is the National Eye Institute Visual Functioning Questionnaire. And these are 25 questions that are a little bit more about how a patient is functioning. So here you're asking a little bit more of how much pain or discomfort, or how much time do you worry about your eyesight? There's also these functioning questionnaires. So more like how much difficulty are you having with things that you do? And so just a little bit different way of questioning, but one is geared a little bit more so towards keratoconus versus the other one's more so for visual functioning in general. So what do we do with all this information, right? Now that we have all of this information of understanding our keratoconus patients better, what do we, what factors do we focus on? I'd say when I went through and kind of looked at all the studies and kind of did, like I said, went down this rabbit hole of like going into the mental health impact, I really did have to take a step back and focus on, all right, what factors do I focus on? I can't focus on all of them all at once because I do think that if, for me, if I focus on all of them at once, I'm not going to do a great job of it. So, what factors do I focus on, and what factors do I think, all right, let this be in the background? How do we make the best decision for our patients? And what is the overall goal of all this? Why are we learning about this? Where do we go from it? First thing I want to say is early intervention. So, early intervention makes a big impact on the mindset of a patient, the quality of life of a patient, and these are things that have been studied. Early screening and changing the referral mindset would be probably the first thing that I would say are things that we can do as an eye care provider. Whether it is for us in our office and early screening, whether you're an office that is seeing a lot of primary care visits, right? And screening patients early, you can start with that. And then if you are an office that is seeing a lot of referrals, you're working with a lot of keratoconus patients, other colleagues are referring to you, learning and being out there and educating others to change the mindset of referring. Maybe referring early for if they're not sure if a patient could have keratoconus, or even earlier referrals for cross-linking. And I'll kind of go through that and how your staff can be helpful to that too. Family history and letting people know that this can be genetic is a big one. For me, in my office, I offer screenings to family members of patients who have keratoconus. We are we have a tomographer in the office, and so I really do like to offer that and say, all right, this can be genetic. If you have kids, if there's some siblings or someone that you would like to have a screening, please feel free to bring them to your next appointment. I'm more than happy to take a look and screen them, right? Having these conversations during the diagnosis and follow-ups about being screened early or early interventions are big for patients so that they understand too. I can't tell you how many times one person has said something to another patient and they'll talk about, yeah, I was diagnosed years ago versus, oh, we didn't even find out till we were later on. And so just knowing that early intervention's happening, and I think we've done great with that with more education, the word getting out there. I think great technology has also helped. And then earlier referrals for cross-linking. That's a big one. So that's a big intervention that can be done earlier. Um, that's another thing that I will say that has changed in the practice and how I work. When I was first getting my first few referrals, there were referrals. It was a new practice. I was excited to get them, right? And for me, it was just, all right, we're creating a baseline with the machines that we have here now. But I will tell you, there are many, many times that I go back and I look at, or I will try my best to get the information from other offices, ask the patient, what other offices have you gone to? Gathering that data and then being able to look at the data and screen for progression and then sending them out as soon as you can versus maybe seeing the patient and then saying, oh yeah, I'll see you back in 6 months and then we'll see if you're progressing. That early referral makes a big difference for many patients. The goals. What are our goals? And what are the goals that we're setting up not only for our patients, but also for ourselves, right? What are you focusing on in your office? So these are questions I'm going to ask you now. And what are your goals realistically for the office? Following up on these goals is also something that you need to plan. I will say these are all things I have said to me myself in my head, and so that I share that with you because sometimes I'll have a goal, we'll do something, and then we completely forget about it. So from a follow-up perspective, every office meeting we have, we do stop and talk about, hey guys, how's it going with our keratoconus referrals? How's it going with our patients? And that's the same thing I'll say to patients and even their families when they come in. What are your goals? All right, what's your next goal? What do you want to do? Is there something that you want to do with your, life that you feel like you can't because of your vision? And then finally, really celebrating the wins. After a patient has cross-linking done, they're done with their post-ops, I really make a point to stop and tell the patients, all right, guys, we did it. We did it, right? It was a lot to process. It was, I know, you maybe had trouble with that one eye. It was a little bit more painful than the other one, but we did it. Look at us. We're 6 months post-op on your second eye. All right, we got this. Guess what? You don't have to come in to see me so often anymore. Usually that's a sign of relief for most patients. So really celebrating the wins with our patient is also something you want to keep in mind. When we look at our treatments, I would say these are the treatments we commonly do from a visual perspective, right? Glasses, contact lenses, specialty lenses, and then what surgical options. But I want you to stop. I want you to stop and take a look beyond our exam rooms and take a look at this as a full kind of comprehensive care for our keratoconus patients versus just visual care. Are you discussing options outside of vision correction? Are you focusing on the mental health part of a patient? Things like acceptance, compliance, fear, the outlook the patient's having. And then let's start shifting the emphasis again from just visual care to the patient, for the patient, to a patient-centric approach. That's really kind of looking more at complete care. With that, looking at coping and learning methods has been a big change that we've incorporated in the office too. We have a therapist that does focus on some of our patients that have vision impairments. So she first started off with us, I think more so on keratoconus, understanding that and being someone that was a little bit trained with vision impairment. But now she's focused not just on keratoconus, but also other parts. So it's been great to being able to offer to patients that have vision impairments from not just keratoconus aspect of it, but others also. And it's been interesting of all the different things that she's incorporated with some of our patients. So one thing is mindfulness-based cognitive therapy. So that's a combination of traditional cognitive behavior techniques with mindful strategies. Really tells a patient to be more in the moment awareness, things like meditation and breathing exercises, but it also stops a patient from and breaks away from that negative thought aspect that they can go down. Another coping and learning method is behavioral activation. It can increase positive reinforcement through rewarding activities. So it helps with avoidance. So I'll tell you an example of this is when patients do come back for their follow-up appointments, rewarding them, or sometimes when I do refer them to a surgeon or to a different office, what I like doing is, why don't you do this? Why don't you text me? Text me and share with me your experience after you go to that surgeon's office or the referral, right? It makes it so that they feel like they're getting rewarded because they can talk to me and I'm more like a cheerleader for them. And so those are small things that you can change in the office. Something else is progressive muscle relaxation. It's a coping method that you can go over with patients. And what it is it's systemically kind of tensing and then relaxing different muscle groups in their body. And it helps them kind of alleviate from the worry, the anxiety, or the fear of something. This is something that you can incorporate, especially if patients start getting nervous or with insertion and removal of specialty lenses. Many of our patients in the beginning do get nervous of that. And so they can stop and do this tensing and relaxing kind of exercise so that they can get their mind off of what they're about to do. And it helps them relax before they start maybe inserting the lens. Compassion focused therapy is something that aims to help patients with self compassion and reduce self criticism. Mindfulness based stress reduction is something like mindful yoga, meditation, planned activities. So we've even tried to have nights where we have Keratoconus yoga night. We'll go through different exercises or have had different yoga instructors that share little kind of a pamphlet of different exercises that some of my keratoconus patients can do so that they can have this stress reduction. And these are all small things that we can add in our education packet, let's say if you have one. Lifestyle-based approaches that can help our patients is positive expressive writing or experiencing awe in daily life and taking that one moment of something that just made you stop and go, wow, and maybe writing it down. We have these journals. So I love giving out these journals for patients that I know that like writing because then they can take a moment and maybe write their experience. Maybe they can write down things about keratoconus they've learned. They take it with them maybe to the referral appointments and then kind of it's their keratoconus book, right? And they can write down what they think, or they can add papers in here that have to do with learning how to wear specialty lenses, or they can write down their drop schedule for cross-linking. But it's their one kind of book that they have. And sometimes it can be a positive thing for them because they can, I have some that like to draw and they can draw little things in there. Exercise and physical activities kind of make them more group-based. And I'll talk about a little, one of them, which is the Keratoconus Run Club. So we started this for a little while. This was a way I made myself run a little bit. So we had it for a couple of nights. I think we did this last year, but we didn't really continue it this year because the attendance was pretty low. But it's something that we tried, right? Other coping methods can include prism neurofeedback technology. This is definitely not my forte, so it's something that the therapist that works with our patients has recommended to a couple of patients. And what it is you're using PRISM, which is basically splitting or filtering brain signals. So they use EEG to help patients regulate their own brain activity. And we've done this twice with patients now. So there's been two patients that we've done this with, and this is more so with their anxiety of inserting and removing contact lenses. And overall, it's really helped them so that they can get past that anxiety and fear with contact lenses coming close to their eyes. Deep breathing, grounding techniques are there, journaling, and social support. So these are all things that are outside and beyond the exam room that we can really do for our patients. Things that you can do in office that can change. This has definitely been a learning point. I opened a cold start practice a couple of years ago, and so it's been a great learning experience for me on how to train other staff members as we've had staff changes. One of my biggest things I like to do with each staff member that joins our team is really educating them on keratoconus. So as we have training on how to use EHR and, overall how to bring back a patient and HEPA training, you get keratoconus training in the office also. And it's because I want them to know exactly what keratoconus is. And so when they understand what keratoconus is, what can happen, what these patients go through, I think that helps them also understand the severity of when we get a phone call for referrals, why it's urgent to address that, right? Maybe it might not be as urgent as flashes and floaters in some offices, but for us, it definitely is something that warrants a conversation with me. And urgency, as in, is this someone that is progressing? Is this someone on the younger side? Or is this someone that's just coming in for a specialty fit that has keratoconus, right? We've also talked about things on different techniques on how to talk to patients on the phone. They can be nervous. They may not know what keratoconus is. They may just, it may be a referring doctor that may think a patient has keratoconus and now they've Googled everything. So it's nice to have my staff be aware of what keratoconus is and be able to kind of let them know, okay, what kind of appointment they're coming in for. And then again, with adult versus children referrals, I'm very fortunate that the office is doing well in the fact that we are a little booked out, but there's always place for if there are young children that are progressing, and those referrals should be brought and that should warrant a conversation with me versus maybe waiting a few weeks out. So that kind of training goes a long way with our staff. Gathering data from all previous offices. My front desk staff does do, I'd say, do an excellent job of making sure they ask the patients, all right, what other offices have you been to? And making sure that they get that data. So when I am reviewing it and looking at patients, all right, what were their keratometry readings maybe 4 years ago? And where are we now? Versus just going back one exam in time. And then guiding patients and parents through the testing. That's also been a learning process. There's a lot of tests that we can do in the office. But also finding the sign that the patient is getting overwhelmed. It can be a lot. Explaining each one of the tests to the patient. So starting off with, this is what this does. All right, this is what the next test does. All right, this is the stuff Dr. Brigat's going to go over with you, right? So it's good for the staff to know that and also pick up on signs that are, okay, this is too many tests. They're getting nervous. All right, let's bring them into the room. Let's bring me into the room finally, right? And then maybe taking a pause at it. So understanding the signs of overwhelming the patient is also something that I've reviewed with the staff. And these are all things that you can do in staff training that can go a long way for the experience that the patient has. So when it comes to just a couple of cases that I had, I'm gonna go through this one and then I'll hold off on the other one. But this one was this patient I was telling you about earlier, the 22-year-old art student. She was referred from a colleague. The patient had seen several eye care providers over the years, and she had complained of vision changes. The eye care provider suggested first multiple different glasses, and then she finally switched the person, and she went to a doctor who I've known for a long time. They basically diagnosed her with keratoconus, sent her to the office to have testing done, and then to move on to have cross-linking. And she started wearing specialty lenses. This patient, after everything she went through, she was so excited to she was happy that she had gone through that and somebody had given her an answer, that she actually wanted to start a mentorship program. And she is now doing a mentorship program with some of our younger patients to help guide them and their families through the keratoconus process and cross-linking and other options, and to help them in any way that they can, just to even know that there's someone else out there. So so her and her mother both wear sclerals, and it's interesting because they actually created these for my office for each one of the patients after a lot of trial and errors of seeing what works for them. And so now this is something that we give out when we do our specialty lenses. So it's kind of neat to have these patients still be involved in many ways and help others with their journey. Little roadmap here that I want to talk about is kind of the different phases of what you want to think about when it comes to managing, again, that diagnosis and treatment part. So education, in-office and materials to take home and review, right? Then there's the treatment plan that you want to go through with your patients based off of their needs and capabilities. Next, referrals, communicating with referral doctors, making sure you're co-managing, making sure that they get all the information that they need, not just with the co-managing doctor, but also for the patients, so that they know where they're going, what to expect at these appointments. And then looking at a long-term care outlook. So making sure that they review with the patient, all right, These are the things that this is not just one appointment. You will be back for a few appointments. What to expect on the long term. Keratoconus is really a multidisciplinary diagnosis. You have specialty lenses, surgical care. I want you to start thinking about therapists and other providers. And it's also very intricate and delicate. So from the presentation to the lifelong management part, I want you to also start thinking about what are the things you're doing now and what can you change to maybe improve that. And think about that beyond just the correction from a perspective of awareness, resources, and finally, just from compassion. Two recommendations I have to make is that I would say pick one aspect outside of vision correction that we kind of went over today and focus on that and change that in your office. Like I said, whether you're a primary care office that's just screening patients for this or a referral site, pick one aspect. And then second, focus on sharing the message of early screenings. That early screening leads to early treatments with patients and helping them guide them through their keratoconus journey. So again, this is beyond the cone, right? 2020 is not the endpoint in many of these cases. And I want you to know that that's not the only thing we're looking at. Let's start looking past what we see just with glasses and contacts.